Thank you everyone for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, just wanted to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speakers today. If you have any questions for our guest speakers, feel free to use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speakers will see them. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, information, please ask your doctor. So next, I would like to introduce you all to our guest speakers today. Today we have Sandra Elliott. Sandra is a bicultural and trilingual domestic violence advocate and counselor with the Haven program at Mass General. She has worked with survivors of intimate partner violence for close to 30 years. She previously worked as a training coordinator for the Boston Public Health Commission Domestic Violence Program. Sandra was also an assistant program director at a community-based domestic violence shelter. Joining us today, we also have Raina Burdett. Raina is a domestic violence advocate with the Haven program at Mass General in the Revere Healthcare Center. She has worked with survivors of intimate partner violence since 2016 and has been with the Haven program for over 2 years. Raina has experience working in residential and community-based settings and has previous experience assisting with housing, accompanying survivors to court, and facilitating groups. They join us today to give a talk on intimate partner violence and advocacy in the medical setting. So please join me in welcoming Sandra and Raina.
Hello, everyone. Thanks so much for being here. I will pull up the slides and we can go ahead and get started.
All right. Hello, everyone. It's really a pleasure to be here with all of you today. I'm Sandra, and before we get started, I would like to put out there that this can be a very sensitive topic since we're talking about intimate partner violence, and we want to be mindful that it might trigger some of you and bring up some emotions and feelings, and we want to make sure you have a safe space to take care of yourself, take time off, or turn your video off. And if you want to talk to someone in our program, you can call the Haven number, which is 617-724-0054. And today, Raina and I will actually go over some of the basics around intimate partner violence and what the advocacy looks like in a medical setting. So Raina, if you can pull the next slide. Oh, there it is. Okay. So we want to start by talking about what Haven does. What are our services? What do we offer? Haven actually stands for something. It's actually Hospital Helping Abuse and Violence and Now. A lot of people don't know that, but that's where the name kind of came from. We are a free, voluntary, confidential, multilingual program. And when we say voluntary, people have to agree to talk to one of us. Usually a provider will mention our program and will offer whether or not a patient, a client, anyone would be interested in connecting with one of us. And that person has to agree to either have someone from our program reach out to them, or for them to feel comfortable calling us Monday through Friday from 8:30 to 5. The free part is it's actually quite important since we are talking about intimate partner violence. People don't have to worry about health insurance, especially if they're on their partner's health insurance. So it's the one thing they do not have to worry about. And multilingual staff. So we can provide, in addition to English, services in Spanish at all the sites. So we have 3 sites. So we're in Boston, Chelsea, and Revere. So in addition to English, Spanish, all 3 sites, and then in Boston, Haitian Creole and French. And of course, the confidentiality part. Our services are confidential, but I have to point out that we are mandated reporters, which means if there's abuse or neglect of a child under the age of 18, of an elderly person over the age of 60 or 61, and a person with disability, as mandated reporters, we have to work with agencies that will deal with that. But we usually always have a conversation with our clients before doing any filing. So that's that's the piece about the confidentiality and where we would need to break confidentiality. We use an empowerment model, and what it means is really respecting our clients' decisions and choices and options, because there are in situations where they usually don't have a voice, where they're usually pretty isolated, that it's important for them to know that we want to hear what they have to say. We want to hear about their feelings, their emotions, how what they're experiencing is impacting them. So that's really what the empowerment model is all about. So really drawing on our clients' strengths, and they can be very resourceful. People stay in relationships for a very long time, and we are always amazed at how thoughtful and resourceful they can be. And these are the things that we talk about. We also use a very trauma-informed approach. And what it means, because we know that when we talk about trauma, it can be very difficult and painful, and actually make it more difficult for someone to be able to share their experience. So we really give our clients, the setting that they can tell us as much or as little as they feel comfortable, because we don't want to re-trigger them. We don't want to re-traumatize them. So really respecting where they're at, and taking it from that point, and being mindful of the fact that not everybody is going to share their story in a way that's always going to flow, and respecting that their timeline. So that's kind of the trauma-informed piece of that. In addition to the counseling piece, so talking about the empowerment model, talking about trauma-informed, it's really the work that we do when we provide the counseling part of our services. The other client services, patient services that we do provide, in addition to the counseling, is advocacy. What does advocacy look like? It's really a range. So we provide advocacy around housing, which is one of the more challenging part of our work, because we know the housing situation in Massachusetts, but we really kind of work with our patients, with our client around whatever options are available to them around housing. What documentations are needed, helping them to gather that. So these are some of the things that we do. Because we are in a hospital, we do medical advocacy as well. And that can be from helping a patient, a client, getting access to a medical provider if they've never had that, or if they're experiencing some difficulty with their health insurance, if they get care here at the hospital, we can usually kind of guide them about resources here in the hospital, about how to take how to take care of that, helping them to set up an appointment with a medical provider. And we even have accompanied some of our patients, some of our clients to medical appointments here in the hospital. So that's some pieces of the medical advocacy. We also do financial advocacy. Just like the housing, it's really talking about what financial options are available to our clients, to our patients. What do they qualify for? What's available to them? So providing them with education about financial resources. We also do legal advocacy. The legal advocacy piece of our work is a little bit more extensive in the sense that we're very lucky that we're part of a legal partnership with another community-based program, which has a pretty big legal department. And years ago, we had received a fellowship to be where they were able to pick 2 or 3 hospitals, programs like the Haven program, also in other hospitals, and work with us around specifically family law issues. That means things like divorce, child support, custody, paternity. So anything related to family law issues was what they were assigned to work with us on. And it really was a pretty amazing resource to have, because we have access to an attorney who can answer questions around family law issues. Or one of them is also restraining order, information around restraining orders. So that attorney can provide free legal consultation to our clients and to our patients. They do very, very minimal representation. If a client or a patient needs representation, then they'll either make a referral, and depending on what's going on with the client, they might be able, like I said, to do very limited representation, but they would definitely make a referral to our clients for legal representation. We also provide support groups. And here in Boston on the main campus, we have had support groups. We have had what we call educational workshops, where we have had specific topic to cover. One very popular topic is for parenting with a parent who uses abuse. So it's a very popular workshop that we've had here on the main campus. At the Revere Health Center, for instance, Rain has run a number of support groups, ongoing support groups with clients, and also providing, and these support groups, each week, it can go from 8 to 10 weeks, so 6 to 8 weeks, and each week a different topic is addressed. In Chelsea, our advocate in Chelsea has been able to provide support group in Spanish for Spanish-speaking clients. So again, a range of support groups. Another big piece of our advocacy work is safety planning, safety assessment, and safety planning. A lot of the times, I think that's what brings anxiety to a lot of people. When they hear about a situation, it sounds pretty scary, it sounds pretty concerning, and we always encourage providers to reach out to us so we can do a more in-depth safety assessment, so we can then do safety planning with our clients, with our patients. And accompaniment is also another part of our work. I know I mentioned accompaniment when I talk about medical advocacy, but we do accompaniment. We go to court, we accompany clients and patients to court if they have an interview or an appointment, let's say with housing. We can accompany them. We have accompanied clients to the Department of Transitional Assistance. This is where people can get some financial help and financial resources, because these systems can be very hard to navigate, and they can be very intimidating systems to navigate. So our presence, the fact that we can accompany them, makes it a little easier on our clients, a little easier on our patients to be able to get what they need. So this what I just described are the services we provide to patients. For providers, we are also available to you to do consultations, because like I mentioned before, this can bring a lot of emotions and feelings for folks. And especially when a provider, let's say, gives a patient Haven's information, the patient is not ready to make a connection with Haven, and it can cause some anxiety, some concern, some worry for providers. So we always encourage providers to reach out to us so they can kind of process all that and talk to us about it. And also sometimes people call to consult about, how do I talk to someone about what's going on? How do I approach the conversation? Because I have a feeling something might be going on with my patient, but I'm not sure how to start the conversation. So we really do consultations on a range of different things related to intimate partner violence. In some cases, it's consultations around documentation. How do I document, or whether or not I need to document in the medical record? So these are just some examples of consultations that we provide. Also, we do a lot of debriefings when a difficult case presents. We've gone on different floors because we've had situations where a client or a patient is admitted because of having been severely assaulted by a partner, and people on the floor, nurses and other medical providers, physicians, need a kind of a place where they can process, they can debrief kind of what's going on the floor for them with that particular patient. So we are available to do that, to go on the floor and meet with the staff and talk about what's going on and help them to process the whole situation with the client or the patient. And of course, trainings, just like the one we are doing today. Any department, any group who's interested in having us come and do a training for them, we are always happy to provide that. And we really tailor our trainings to what the department or the group is looking for. And sometimes we have an hour, sometimes we have 45 minutes, 20 minutes. We can make it work. We have 2 hours, we can make it work. And as I mentioned earlier, we are located on the main campus here. We also have advocates at the Revere Health Center, where Reina is one of the advocates, and we have an advocate at the Chelsea Healthcare Center. So now, sorry, Reina,
No
you
problem.
can go ahead.
Okay, thanks, Sandra. Yeah, thanks so much for the description of all of our services and everything. So we just wanted to kind of highlight some of the terminology that we use in the work that we do overall, as well as the terminology that we will be using today throughout the course of the presentation, as well as in the session on Monday, if y'all choose to attend that one as well. So the first things that we want to highlight is really just that the language in the domestic violence field, as well as in the, just kind of general like social justice field and things like that as well, the language is always changing, and we really try to be cognizant of that as a team. And part of that is, of course, asking for and using the correct pronouns of the folks with whom we work, as well as colleagues and members of the interdisciplinary team. So we try to think about, using words like healthy and unhealthy relationships as well. And then the next two pieces, the domestic violence versus intimate partner violence, oftentimes these are kind of used interchangeably. However, domestic violence in particular, that expression can sometimes be used, and by some even local community-based organizations that work specifically with, or that work with like broader domestic violence survivors or survivors of domestic violence. Sometimes that can include different types of relationships like roommate relationships or familial relationships. So domestic violence is sometimes more of a broader like umbrella term. However, more specifically, what Haven specializes in and the folks with whom we specifically work are survivors of intimate partner violence or partner abuse. And so, like I said, we specifically work with this population, as well as, the word partner in particular is used for to keep it gender neutral, at least until we know the pronouns that folks use, as well as not assuming the relationship between folks. So we would rarely be like, oh, what's going on with your, husband or something like that. It would have to be partner. So, and people can choose to tell us what relationship they have with other folks in their lives. We also like to use kind of more generalized, especially when describing our services, kind of more general language, things like relationships with safety concerns. And then some of the next ones are really some outdated language that we still sometimes see in different systems, but language that we really do not like to use. So for example, the word victim, we choose to not use that. We often will use survivor to describe folks with whom we work. Same thing with the next line to describe somebody who uses abuse. We really oftentimes will try to use this person first language to describe, a person who uses abusive behaviors. And this even is a change kind of from what even Haven used to do. Like in preparation for this presentation, we were going through previous presentations, and we have, the word like abuser in a lot of those slides, but we don't generally use that language anymore. We try to use the person first language when we can. And then same things with education programs for folks who use abuse. The names of those have changed over time. I believe the most updated one is the intimate partner abuse education programs. Those are the groups for folks who use abuse. We don't run any of those. We work specifically with survivors, but if you've ever heard of those, that name changes as well. And then another piece of language that we don't use in terms of talking about folks who have immigrated to the country, we would not use words like illegal or anything like that. We instead, again, use the person first language and describing folks who are without status or folks who are undocumented here. Sandra, anything to add before I move on?
No, you pretty much covered it.
All right, awesome.
Okay, so what is the definition that Haven uses to be able to assess a relationship, whether it's unhealthy, or is there a pattern that's going on that makes it, that makes it abusive? So the definition that we use, so intimate partner violence is a pattern of coercive control by one intimate partner over another, and it may include emotional, psychological abuse. With the emotional, usually it also includes verbal, so emotional and verbal. Sometimes I tell people it could be two different things, because the psychological impact of emotional and verbal abuse can be pretty devastating. And I can give some example after I read the definition. Isolation, manipulation. One of the easiest form of abuse that people usually are quick to recognize of is physical abuse, also sexual assault. There's also what we call economic control, threat, stalking, and other form of harassment. And this different coercive this different pattern of coercive behaviors are used to establish and maintain power and control in the relationship. So what happens, it's really looking at who in the relationship, whose life is getting smaller and smaller, and who has complete power and control over the other person. And that's how we do the assessment. Some quick examples of emotional and verbal abuse. And I think I picked that one because sometimes they can be very subtle, and it's a lot harder for people to recognize that this is what's going on. You know, for instance, the name calling, the put downs, you know, when somebody constantly tells you you're nothing, or you'll never leave me, or nobody will want you, and, you know, over and over, the emotional and psychological impact of that really affects our clients in very devastating ways, where they feel like they're not worthy of anything, and they feel like they deserve what's actually happening to them. And sometimes I have people calling and saying, I'm not sure if Haven is the right place because I haven't experienced physical abuse. And as I start to ask more questions, I realize that there's verbal and emotional and psychological abuse going on. And we talk more about that. We explore that more. And I tell people that it can actually be more devastating than physical abuse, because the bruises go away and they heal, but the emotional impact of continuous pattern of emotional and verbal and psychological abuse can be really, really devastating. And again, it's so that the other person, the person who uses abuse, can maintain power and control over their partner, and also making it hard for the partner to reach out for help, to be able to be believed, because usually people who use abuse present well. You cannot walk around and say, oh, this person uses abuse, that person uses abuse, so this person is being controlled. We cannot tell that. And so these are the key things that we look for when we assess for clients, to make sure that they're a good fit for our program.
Yeah, thank you. So we also wanted to highlight just the broad impact of intimate partner violence, and really just highlight that intimate partner abuse unfortunately impacts folks of all cultures, races, classes, religions, ages, genders, sexualities. We work with folks kind of in the cross section of all of these, and it really does impact kind of just across all of those. Intimate partner violence does not discriminate. So, however, that being said, folks who are immigrants, refugees, folks with disabilities tend to face additional risks, both within the relationship itself, as well as kind of within the systems of somebody trying to have access to resources in the community, or things like housing, things like police interaction is very different, restraining orders, things are, just they face additional barriers. So a few statistics. This one's from the National NCADV, National Coalition Against Domestic Violence, I believe.
Yes.
So 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner. I believe that's kind of across a lifetime, and that is, again, only physical violence. And as Sandra just explained, a lot of folks with whom we work don't experience physical violence and experience other types of abuse primarily. And then a few statistics from the network LaRed, which is a local organization in Boston that works particularly with folks who are LGBTQT, as well as poly and members of the S&M community who work with survivors in those communities. And so these two statistics are from them or their website. They report that 25 to 33% of LGBTQT people experience abuse by a partner, as well as an estimated 1 in 4 LGBTQT youth will experience abuse from a dating partner. We also just wanted to highlight specifics of teen dating violence, as well as elder intimate partner abuse. These are very common and not as frequently spoken about. There is a full month actually for teen dating violence awareness in February, so we do some work around that, but just wanted to really highlight that abuse can occur across all of these different identities, as well as in kind of many stages of somebody's life.
So the next thing is to talk about barriers to leaving, because one of the things we hear a lot when we talk to clients is when people say, why don't you leave? Why don't you just leave? And it's important to understand that it's actually, there are so many barriers and so many struggles for our clients, for so many people to be able to just walk away from a situation like intimate partner abuse. So we kind of listed a couple of the reasons, a couple of the barriers to why it's so hard for someone to leave right away, or to leave at all. And for you to know, all of you to know that the majority of our clients are still very much with their partner. And it's one of the things that we tell people. We don't tell clients what to do or to leave their partner. That's not a choice that we make. They make that choice. And that the information that I'm going to be talking about, these are the kind of things that we talk to them about, they talk to us about. So some of the barriers, housing is one of the biggest one. It's especially a lot of our clients, a lot of our patients are not working. They are dependent on their partner financially. And again, that's a form of control. Even if they were working or they could only work part-time, for instance, basically not making enough money to be able to afford a place on their own. Or if there are children involved in the situation, the partner will say things like, I will not pay for child support. So housing is a big one. Safety is also a big reason why it's hard for someone to leave, because leaving is actually one of the most dangerous time in a client's life, because once the person who uses abuse realizes that they no longer have the kind of control over their partner that they thought they had, we see a lot of the time that the violence will escalate, that the abuse will escalate. So safety is really a major reason. And the FBI had done a study where they said it takes about an average of 6 times before someone can actually completely leave an abusive relationship, because of all the different factors that I'm going to keep talking about. And sometimes, the systems has failed them. That's another piece. So financial needs, which is a huge one, not being able to have the money to get away, or even we have clients who are working, but they know that their salary alone is not going to be able to support a household, especially if there are children involved. So that reality is huge with so many of our clients. Mental health. We have many of our clients who struggle with mental health, and sometimes because they are on their partner's health insurance, it's a lot harder for them to be able to access mental health services. And that's why sometimes when they come to us, we don't provide therapy, but we try to help them to see if we can get them connected to a mental health provider. But like I said, sometimes it presents its share of challenges, especially when they're on their partner's health insurance. Shame and guilt are two big pieces as well. A lot of our clients feel somehow responsible for their partner's behavior. They feel bad, they feel ashamed and embarrassed and guilty about what's going on. Some of them feel like they deserve what's going on, what's happening to them, because that's the kind of language, that's the kind of tactic that the partner will use. And a lot of our clients will internalize that and believe that they're the reason why all these things are happening to them. So they're not putting the responsibility back on the partner, on the person who uses abuse. Language barriers, like Reina said earlier, we work with a lot of immigrants because we also a multilingual program. Language barrier, language is a big piece. People, I've had clients who've been in the US for a long time, but their partner will not allow them to take English classes, for instance. So they cannot communicate with the outside world. So it increases their isolation as a result as well. Also, lots of misconceptions. A big example, we have situations where clients will say, I don't believe in divorce. I don't believe in, having to go to a system and get separated from my partner. Another big misconception, nobody's going to believe me. Nobody's going to help me. The systems are, they're not there to help you. So that's a big one that we hear a lot. And again, another misconception, another myth, because we have a lot of myths in this, is that your kids are going to be taken away from you. That's when we hear a lot of, if you do this, you're going to lose your kids. So these are just some examples of what we hear. Cultural factors, and it's something that we hear a lot about. Clients saying, in my culture, this is completely acceptable. In my culture, it's okay for a partner to behave that way. This is because you have to be submissive, and so they're allowed to punish you if you don't do what they want you to do. And that can be, again, we internalize, if we grow up to believe in certain things, we internalize it, and we believe it to be true, and that somehow it cannot be challenged, it cannot be changed. So we have a lot of conversation about cultural factors. A sense of powerlessness, clients coming to us and saying, what can I really do? I don't have any skills, I don't have anything, I've lost all support. What can I really do? Nobody's going to believe me anyway. I can't do anything. Again, messages that they've heard from their partner that they've internalized and they believe about themselves. Immigration status, that's a big one. Many of our clients who are without status, who are undocumented, hear a lot from their partner. If you reach out to anyone, if you call the police, if you say anything to your medical provider, I will make sure you'll get deported. We hear this one over and over and over again. There's also a sense of loyalty, because the thing about intimate partner violence, there's a cycle, and we'll talk more about that, where things are not bad all the time. There are times where the partner can actually behave in a way that gives our clients, our patients, hope that they can be changed. Change can happen. So hope, which comes after that. I've even had clients say to me, I still love my partner. I don't like what they're doing to me, but I still have feelings for that person. I've made a commitment to that person. We have, let's say, if they have children, we have children together, and I care deeply about that person. So that's also a reason. And of course, when I talked a lot about the systems that are put in place to protect. A lot of the time, these systems are extremely broken, extremely flawed, and they've gone to these systems, and a lot have had very negative experiences, very negative outcomes, because they were not heard, they were dismissed, they were not believed. So all the worries and misconceptions and some of the things that they hear from their own partner is kind of what's happening with some of the systems that are in place to protect them. So I don't know if there's anything else you want to add, Reina?
No, I think that's definitely not a comprehensive list. Unfortunately, you know, like we see many of these all the time, and there are definitely many more, but just in brief, yeah. So thank you. Briefly, and we don't have too much time left, so just wanted to quickly go over some of the types of abuse that sometimes will occur. So as Sandra mentioned in the definition, what we always come back to in terms of thinking about what domestic violence is, or sorry, what intimate partner violence is and what it actually looks like, is really just this one person trying to establish and maintain power and control over another person. The different types of abuse is maybe just more of a description of like behaviors that might contribute to the power and control trying to be maintained and established. So these are some of the main forms of violence. There's of course physical violence, which is kind of the one that we see most frequently in, you know, like television and movies, and is one of the more alarming and dangerous, as well as Sandra says, a lot of folks call us and say, well, I don't know that I'm experiencing violence just because there has never been any sort of physical abuse. There is also sexual abuse, which, other than some of the bigger ones like sexual coercion and rape, are also things like reproductive coercion, and trying to establish and maintain like power and control in terms of decisions around reproductive rights. Emotional abuse can include things like gaslighting, which is crazy making somebody question their version of reality, monitoring, isolating, being excessively jealous, and like a lot of accusations of cheating. There's also verbal, which are things like name calling, yelling, and screaming. Financial is actually really, really big, and not often talked about, even in the partner abuse world, but is often very common, especially with folks with whom we work. So this can even be things like, we hear folks say, or I hear all the time, like, you know, every time right before I go to work, somehow there's a big fight, and or like asking, forcing somebody to quit their job, or taking somebody's money, or saying, yeah, I'll take care of all the bills, you can just give me all your money, like from your paycheck and stuff, and then not paying, ruining credit, maxing out credit cards. So anything kind of at the financial and control. There's also a lot of other types of abuse as well. So things like religious control, as well as a lot under digital, which we speak more about with young folks, but applies to everybody kind of in this day and age. There's so much that can happen there in terms of like even, you know, tracking somebody's location without them knowing, and demanding access to social media accounts, things like that. So really anything but everything should come back to this like power and control in terms of thinking about partner abuse.
So I'd mentioned earlier the cycle of abuse when I was talking about barriers to leaving. So this is what it looks like. And we see this pattern over time with so many of our clients. So you have the tension building where clients talk about feeling like they're walking on eggshells, they're waiting for the other shoe to drop, and kind of trying to anticipate some of what can happen with the partner. So it's very, very tense moments during that time. And then you have the actual explosion, the actual incident of either verbal, more emotional escalation that happens, physical, it's really, it's almost, some people will describe it almost as a relief, because it's just, as when you walk on eggshells and you're waiting for the other shoe to drop, you just want something to happen and kind of get it over with, as many of our clients and patients say. It's very difficult because, again, of the impact that I talked about earlier. And then you have what we call the honeymoon phase, the honeymoon period, where the person who uses abuse will apologize. It'll never happen again. Will make promises of change. The behavior will seem like, oh, my partner is taking responsibility. My partner feels bad. My partner apologized. So that's where the hope comes in, and the loyalty, because they see that side of the person who uses abuse, and it gives them the hope that there's going to be change, things are going to get better. But what we've known and what we've learned and what we've talked to our clients about is that over time, the cycle of violence, so the tension increases, the acute explosion also increases, and the honeymoon phase kind of shrinks. So over time, you get to the point where there's barely any honeymoon phase anymore. It's tension. There's a lot of tension building and a lot of kind of explosive moments, and a lot of denial, because people who use abuse never really take responsibility for their behavior, for hurting their partner the way that they are. And it's one of the things that's really hard for so many of our clients. And that's why they internalize a lot of the messages and feel responsible for their partner's behavior, because the partner never takes responsibility. They never recognize, they make excuses. They feel very entitled and very justified to behave the way that they do. Some will use things like, I had a horrible childhood. I had, things were not easy for me. So they feel justified and very entitled to behave the way that they do. So that's why that cycle of violence continues to happen, because there's no accepting, there's no recognizing that they have a problem, that they need to take responsibility for what's going on, but they put it all on our clients, on our patients. So that's the piece. And that's how they're able also to maintain that power and control, because the tension phase gets longer, the explosive phase gets longer, and sometimes the honeymoon is gone. There's no honeymoon phase anymore.
Yeah, absolutely. Thank you, Sandra. So we also wanted to highlight the differences specifically between maybe the work that Haven does in the hospital setting, as well as maybe a more community-based partner abuse program. So both Sandra and I have actually worked in both types of programs and worked for both types of programs, although it's been a few years since we've done community-based work. So these were just some of the things that we wanted to highlight as some of the differences. One of the main ones, one of the biggest ones, is the access that MGH has, that we in the MGH community has to reliable and great medical interpreters through both interpreter services as well as CERCOM. It is awesome for us to, provide access to services, Haven services in multiple languages, and yeah, it's wonderful. Something that we use like almost every day. And another thing that is different about our services here are, of course, just the varied and maybe higher. I of course can't speak for numbers of all of the community-based organizations, but we definitely have varied referrals. So we get referrals sometimes from communities like DCF or community organizations. However, a lot of our referrals come from within the MGH system. So like here in Revere, I'll get referrals from social workers here, from mental health clinicians here, from doctors. Sometimes in Boston, I know we receive it from just folks who maybe have heard of us, who haven't even worked with us directly, but colleagues and things like that. We also work with employees of MGH as well. I don't know if we specifically mentioned that, but we do.
Mention that.
And also in Boston, we do inpatient as well as work in the emergency department here in the, so that means actually visiting folks while they are inpatient or in the emergency department. Here in the community centers, like we don't have a emergency department here in Revere, but I will sometimes meet with folks like when they come in to see their provider. I could be in the room or just meet with them while they're here. We also have, of course, a lot of consultation as well as interdisciplinary work. We work much more on a team than maybe would happen in community settings, at least in my experience. And we have kind of the access to medical providers as well. Working with a larger institution like MGH both has pros and cons. There are some resources like interpreter services that's really great. However, of course, working kind of in the bureaucratic system is different than working on I think the last community organization for whom I worked, there were like 12 people there total. So of course, there are just pros and cons to the differences. In healthcare centers, we really try to focus as well on the kind of community connections and relationships with different organizations in the community. I know that it's about 12:50, so I'll just race through the last slide here, and then we can move on to some of the chat and questions and things like that. But so in the community setting, some of the pros are that we don't have a residential program. We don't have a shelter program at Haven. We're like a small program inside of a much larger organization. So some of the community-based organizations are larger than us, however, have not the, don't have the larger like MGH system behind them as well. So some have things like residential programs. A lot of our colleagues in the greater Boston area, some of the programs have housing specific programs, have legal programs. These are great, and we refer a lot of folks to those because we don't have any like specific programs for those. Some also have police partnerships or kind of other community partnerships that we don't have at Haven, kind of being small. And like I said, sometimes community organizations would have like a smaller organization in total, but maybe like a larger advocate staff. Both. And again, these are all kind of generalizations, like, every organization is different and we can't speak for any even community-based organization, but both often provide things like advocacy, counseling, groups, knowledge about and access to resources. And we also all talk like a lot. The domestic violence community or the partner abuse community in Massachusetts is pretty small relatively. We're all on like a listserv together. We try to really help each other out a lot between organizations, and generally know like most of the services provided at a lot of other places, and we'll try to refer out if we know of, oh, this other place does this really well, or other organizations that have housing specialists and it's beyond our scope and things like that. So those are some of the differences between what we might do. Sandra, do you have any last things to add before I see a few chats as well before we go?
No, you pretty much covered it all, Raina. It's
Okay, perfect. So we had just one more about IPV and COVID, but also want to highlight our references as well as open it up to questions if anybody has any questions or comments for the chat. So I'll stop sharing.
Thank you so much, Sandra and Raina, for a wonderful presentation, very informative. We are now approaching the end of the session, so if you have any questions for our guest speakers, feel free to enter them in the chat box. So aside from the phone number you provided, what are other ways that people can reach out to you for support?
Yeah, and we also have another presentation actually on Monday about supporting folks or supporting somebody who is experiencing intimate partner abuse. But I often say, like, we kind of will take referrals like any way somebody can get it to us. So people will call us, people will email us. We all have pagers that we carry at least during business hours. We take referrals via Epic. Sometimes folks will just send us like a direct message on Epic or the staff message on Epic. So kind of any way that you can get one of us, we will pretty much accept a referral. The things that we ask for are the person's name, contact information. If there's any specifics about contacting somebody. So for example, like times of days that's better, or a safe phone number, whether or not it's safe for us to leave a message, like if any of that info is known, that's helpful. And then also, especially if we are going to be making outreach, we, especially in terms of like our services being voluntary, we like the person who's referring to have had at least a brief conversation with this person in which they have confirmed that the client wants to hear from us. So we will often talk to referring providers, whoever they may be, about like, did you explain what Haven is? Like, does this person know that I'm going to reach out? It's okay for like, we are able to make outreach, which is often really helpful, rather than folks calling us directly. However, yeah, it's not, we don't want to make a cold call in which nobody's ever heard of us, and then suddenly it's like this stranger on the phone trying to talk to you about really, really personal stuff. So we like folks to have at least somewhat of a heads up and have given their consent to our outreach.
And do you exclusively only work with Mass General patients and staff, or is this service available to non-MGH patients?
Before the pandemic, and Amy, we would see everybody. So you didn't have to be a patient of MGH to be able to access our services, because since it's a non-paying service, people don't have to worry about health insurance or anything like that. They could reach out to us. Since the pandemic, our numbers are skyrocketed, people reaching out to us. So we had, and because like Reina said earlier, we are a small staff, we had to give priority to MGH patient and employees. So at the moment, if someone from the community reaches out to us, we will, because they are community-based program who do exactly the kind of work that we do, we will refer them to their community-based program. But right now, our main priority are MGH patients and employees. Yes. But hopefully we can one day again start working with everybody like we did in the past. Yes.
And are your services available 24 hours?
No, we are available Monday to Friday from 8:30 a.m. to 5 p.m. So every single day of the week, there's an advocate on call. So if somebody calls and that person is responsible for talking to the client, providing information, we do what's called a phone intake to get all the information that we need. And we do that from 8:30 a.m. to 5 p.m. But we also carry a caseload, which means we see clients. Well, right now we do it mostly remotely, but we have appointments. So we tell anybody who's interested in reaching out to us, if we don't answer the phone, that it's safe to leave us a message. And like Reina said, with the safe phone number and the best time for us to call them back. If somebody has an emergency or wants to reach out after hours, there is the state coalition. It's called the Massachusetts Coalition Against Sexual and Domestic Violence, Jane Doe Inc. And that number is 1-877-785-2020. And that's a 24-hour hotline number. So from 5 to 8:29, anybody can call that number. Also, in the hospital, we do have social workers that are trained to deal with intimate partner abuse situations. So let's say something comes in after hours, the hours that we're not here, whoever's on site, whoever social worker is on site or on call, they will handle the situation, and then will usually either call us or email us to get us in contact with the patient. So even after hours, somebody, a trained social worker will be paid to kind of handle the situation with the patient until we come in the next morning.
Thank you.
Yeah, and I see just a comment about appreciating, Sandra, especially your the inclusion of talking about emotional and psychological abuse.
Okay. Mm-hmm.
And Yeah, absolutely. Just it is something that's often overlooked, like I said,
Yeah.
in things like pop culture and stuff like that, and discussions about intimate partner abuse. But even as this commenter mentioned, it's something that often will really impact somebody for a long time, which makes total sense. Of course, hearing these things and experiencing put downs or whatever sort of abuse over a period of time, it really, those messages sink in, and it definitely takes a while for to come out of that, and that's something that we talk about a lot with folks. So I appreciate your comment, and yeah, absolutely, we talk and think a lot about emotional and psychological abuse.
Thank you. So it looks like we have about a minute left. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
I would just say thank you so much for being here. We really appreciate your time. And we will see some of you maybe on Monday.
On Monday, yes. Thank you again for having us.
So we do have that session on Monday. If you'd like further information on that, including the link to join the session, feel free to email the Blum Center at pflc@partners.org, and we'd be happy to share that with you. Sandra, Reina, thank you so much for informative presentation. Truly enjoyed it. Everyone else, thank you so much for joining us today. As I had mentioned, this session is being recorded, so if you're interested in viewing it, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a little rest of the day.
Thank you.
Thank you.